By the way, I used to be the program manager of the professionals program, and then we had a shake-up at Menninger, and I said, I like director better, so they said, okay, you can be the director. So I like that title a little better. So we went through the list of antidepressants before. Remember that Luvox is used primarily for the treatment of OCD, not OCPD, and that Savella is FDA approved only for the use of fibromyalgia, not depression, but would be effective, but is a little more expensive than Fetzima, its brother, its fraternal twin. So there are other antidepressants as well we talked about. Remember, Surzone, the name brand, isn't around anymore, but Nifazodone is still around. And actually, we talked about how there's such a thing as people are talking about these serotonin modulators that are serotonergic at certain receptors besides reuptake inhibition. And some pharmacologists believe that Nifazodone and Trazodone are both like Vibrant and Trintellix in that way. We don't really use Trazodone much as an antidepressant. I know a few doctors that do. We use it primarily as a hypnotic. It's not as good an antidepressant as some of the other ones. Then tricyclics, monoamine oxidase inhibitors. Remember the diagnostic criteria for major depression. So the studies that have validated the use of antidepressants in psychiatric conditions in depression are really rigorous about making sure that the people who go into the medications trials meet criteria. And so again, you have to have 5 symptoms for at least 2 weeks. It has to be a departure from the patient's normal level of functioning, and at least one of them must be depressed mood and/or anhedonia. So there's this idea that's been swimming around for a long time called minor depression. What if you had 4 symptoms? Or if you had 7, but neither one was depressed mood or anhedonia? Then this is a different entity that we used to call minor depression. It used to appear in the appendix of DSM-4R. Now in the DSM-5 we have depressive episode with insufficient symptoms. So a study appeared in JAMA in 2010 by this guy Fournier, who compared minor and major depression. In this study, they didn't use the number of symptoms as the cutoff between major and minor. They used the score on the Hamilton Depression Rating Scale. And if the score was below 23, they called it minor depression. If it was above 25, they called it major depression. And their conclusion was one that I think is correct under any circumstances, and that is the sicker the patient is, the bigger the benefit. The bigger the benefit to risk ratio. And in fact, some years ago, there was an article, I couldn't find it again, but I had read it before, that showed that in minor depression, people with 4 or fewer symptoms, they actually had worse outcomes if they were treated with an antidepressant. Now, Amy Tutur published a rebuttal to that study who said, the medications they used in this study were older medications that have more side effects. Like 3 of them used imipramine, which, as we saw earlier, is a tertiary amine. So it's got a lot of sedation, a lot of antimuscarinic effects. So maybe constipation, urinary retention, maybe some weight gain, orthostatic hypotension, QT interval prolongation. So it's a little bit unfair to use this one. Now, parenthetically, one of the things I've always advocated for is that when an alcoholic patient gets delirious, you're outside of withdrawal at this point. You now have a delirious patient, okay? So I have always believed that benzodiazepines are not helpful in that situation, and the best authority on delirium is a guy named Jose Maldonado. He's at Stanford, and he says the same thing. He doesn't use benzodiazepines for delirium. If the patient's an alcoholic, he uses valproate, actually, valproic acid. I think haloperidol is a better agent, QT interval issues notwithstanding, because haloperidol, especially if administered intravenously, and some ICUs won't administer haloperidol intravenously. But the reason I'm bringing this up is because the studies, so I've asked a question to my residents, prove to me that benzodiazepines are superior to antipsychotics for the treatment of alcohol withdrawal delirium. Not withdrawal. Withdrawal, yes, benzodiazepines. But once the patient's delirious, you have a different set of circumstances you're dealing with. They all brought me back papers that showed that benzodiazepines were superior to haloperidol for alcohol withdrawal, but not delirium. When I researched this, I looked at 6 studies that appeared in the internal medicine literature in the early 60s that compared benzodiazepines to an antipsychotic called promazine, which is extremely anticholinergic. And so all these studies concluded, yeah, benzodiazepines are superior to antipsychotics for the treatment of alcohol withdrawal delirium. It's not a fair comparison. Haloperidol, I predict, would have had a very different outcome. Promazine is no longer FDA approved for humans. It's only for horses now. So I think what Amy's pointing out here is that a lot of these studies use a tricyclic antidepressant and Paxil, which both have a lot of side effects. But I still think it's true. The fewer the symptoms the patient has, the less likely they are to respond to antidepressant treatment. So I think antidepressants would be an inappropriate use of a psychotropic if the patient doesn't meet criteria for generalized anxiety disorder, panic disorder, or major depression. I think you'd be exposing them to the risk of side effects with a low benefit possibility. Now, I left this slide in this deck even though I've completely changed my mind about it. I used to believe, like most psychiatrists, that dysthymic disorder, which is now called persistent depressive disorder, was not, these patients weren't great candidates for medications. They needed psychotherapy because these are people who are depressed for many years. And so, we think of depression as a discrete biological phenomenon. And these people are like always depressed. I think, Eeyore of, the Winnie the Pooh, he's this guy, So we believed that the reason that they were depressed for many years was because they were using maladaptive strategies monotonously, continuously. And people always quote Einstein saying the definition of insanity is doing the same thing over and over again and expecting a different result. I don't know if he actually said that, but people say that he said that. So I always used to quote Hippocrates, let food be thy medicine and medicine be thy food, and he didn't actually say that. So I don't know if he did or not, but that's what we are accustomed to thinking of dysthymia or persistent depressive disorder. They basically meet criteria for major depression, although clinically they don't look as severe, and it goes on for years, at least 2 years. Anhedonia is not one of the diagnostic criteria, but all the rest of them are there. So the traditional view is that it's maladaptive strategies, and so patients are depressed all the time, that the roots of it were more in personality than in neurobiology. So traditionally we thought that psychotherapy was better for persistent depressive disorder than medication. So that's where rationalism leaves you stranded at the side of the road, because when we looked at it empirically, we found that in fact medications do work for people with persistent depressive disorder, and not only do they work, they get less placebo benefit, so the magnitude is greater. Why do they get less placebo benefit? Because they're very negative people a lot of times, so they're not optimistic, they're pessimistic. So the placebo response was smaller for persistent depressive disorder than it was for major depression. So this study in Psychiatric Times, the author says that the reason that we think that medications work better than psychotherapy is the definitive study has not been done. That would be a study using CBT, regular antidepressant CBT for dysthymic disorder, and that has not been done. They used interpersonal therapy. They used a special brand of CBT, CBASP, a psychotherapy specifically directed at PDD, but not the gold standard. So I think the point here is, even though the medications work better than depression, better than psychotherapy, unless it's maybe CBT, you still have to have both, I think. And this is still widely believed. So bottom line, although many clinicians still believe that psychotherapy becomes before medications, that's probably not the case, but it probably would not be appropriate to treat these patients without psychotherapy as well, because I think that reason dictates that there is a personality component here. A lot of psychopathology in the 100-acre wood. You know, you got ADD, you got anxiety, you got, Christopher Robin with the hallucinations, you know. Anyway, it always, think about it. I mean, everybody's got something in that story. So another thing, as I mentioned earlier, Savella for depression, it is not FDA approved for the treatment of depression. I think it is very reasonable to use in a patient who has both fibromyalgia and major depression. But it's more expensive, slightly more expensive than Fetzima, which is approved for depression. So I think it would be inappropriate to use it first line for depression in a patient that does not also have fibromyalgia. So bipolar depressed, I've spoken to a couple of you here. This is a bear trap that we step in sometimes, both in psychiatry and in internal medicine and family medicine and other non-psychiatric disciplines in medicine, is treating depression in somebody who's actually bipolar. It's really hard to tell when somebody presents with depression if they're bipolar or not. So you have to look for clues. The treatments are very different. You know, if you have a type 1 bipolar who's depressed, we lean a lot more on mood stabilizers and second generation antipsychotics than we do on antidepressants as such. And when I saw this study quoted by Gamey, the authors who cited it said that about 40-some% of patients with bipolar depression get mania rapid cycling if they're exposed to an antidepressant. I read the study and it actually said 23%, so I'm not sure where that came from. But that's still a very high number. So if you have a patient who comes to you for the treatment of depression and you put them on an antidepressant and they get manic, that's obviously a bad outcome. And rapid cycling may be worse. Rapid cycling is defined as 4 or more discrete mood episodes in a year. Think about how debilitating that would be to have 4 depressive episodes in 1 year. So you don't want to do that if you can help it. So what are some clues that you have a patient who's actually bipolar and not depressed? One of them is really early onset, especially prepubertal, but even really young adults, I think. We think in terms of they might in fact be bipolar. If their depressive episodes in the past have been pretty brief, and I mean on the order of weeks, at least 2, but like 2 to 4 weeks, for example, high frequency of depressed episodes, multiple antidepressant failures, particularly where they actually get worse from the antidepressant, erratic responses, a rapid response to antidepressant. You put them on the antidepressant and in just a couple of days they feel better. That sometimes means they're about to flip into mania. Family history, I forgot to mention family history is very important. The 2 most heritable diseases in psychiatry are ADHD and bipolar disorder. So other tips include hypomania. Full-blown mania can be seen from 20,000 feet. You know, the difference between hypomania and mania are twofold. Number one, psychosis. That's easy. So if somebody's paranoid or grandiose, delusional, hallucinatory, they're manic. If they, agitated. There's also, the second definition of mania versus hypomania is needs hospitalization. So that one's a lot vaguer. So mania is pretty easy to see. Hypomania can be subtle. So in patients who've had more than one depressive episode, you know, you can ask them about, have you been through periods where, you know, you weren't exactly euphoric, but you had increased energy, more creativity, and so forth. The mistake can be saying, have you ever had elevated mood? And so irritability or increased psychomotor activity or goal-directed behavior is more sensitive than asking about mood. So increased energy and so forth, but irritability. So this is what we see sometimes. So a patient comes in depressed. They're actually bipolar. We treat them with an SSRI and they go into what's called a mixed state. During a mixed state, they are both manic and depressed at the same time. So they're usually extremely irritable. They may complain of insomnia, but they're not tired from not sleeping. And those individuals respond best to second-generation antipsychotics. There is that increased risk of suicide. They tend to use lethal means. So keep an eye out for early age of onset of the depression, high number of depressive episodes, history of antidepressant-induced mania, which may not look like mania. It might look like a mixed state where they're very irritable, and traits of hostility and impulsivity. Now this is Jürgen Unitzer again. Now the point of this slide is that the Affordable Care Act, and I read this because I had to give a talk on it in Naples, Florida back in 2012, I think it was. My wife and I had dinner there. And so the thing is that I had to read the Affordable Care Act to prepare for this lecture. I agreed to do it without knowing what was in the Affordable Care Act, so I downloaded the PDF and I went, oh my God. So I had already agreed to do this talk about implications for mental health of the Affordable Care Act, and it was 900 pages. And I was like, oh no. But luckily it had a search function. I was able to power through it. And there were many references in the Affordable Care Act to giving grants for projects and programs that did integrated care. So one of the biggest problems we have in mental health in America today is we can't train enough psychiatrists to take care of the need out there. So people like Jürgen Unitzer, who's now the chairman of the Department of Psychiatry, University of Washington, he built his career on creating the integrated care model that I've done the training from the American Psychiatric Association twice. And the model that they came up with is you put an RN, LCSW, or psychologist in a primary care clinic, and let's say you see a patient for depression, you treat them with 2 medications, they fail therapy, then you refer them to this professional who's embedded in the clinic. That individual does like the PHQ-9 or the HAM-D or some other evidence-based monitoring, numerical monitoring, and refers that individual to the psychiatrist with whom they interact by phone and online. So they will do evidence-based psychotherapy on these patients, but will also transmit information to the psychiatrist, and this professional who's in the clinic will keep a spreadsheet of the scores on the depression scales, and others too, anxiety. And so the outcomes of this model are very good, because if the patient doesn't respond, the psychiatrist will recommend different medications. Those recommendations will be passed on to the primary care providers. Primary care providers will prescribe those medications. And imagine having this kind of access to a cardiologist or gastroenterologist or some other specialist. Now, this is very effective because the psychiatrist in this case may only be working 2 hours a week in this clinic, interacting with this professional. But the key is the outcomes are really good because they keep fastidious track of the scores on the depression scales. And if it's not working, they change. So my point is, what would be inappropriate is to treat depression without knowing how it's working. Because when you're keeping track of how it's working, you can do different things. So this is a style of care that's really catching on. Like I said, the training was funded by the Affordable Care Act, and it's very exciting because it brings psychiatric expertise into clinics all around the country. This was an article that I saw in the ACP Internist. Anybody here get this little newspaper in the mail? So ACP Internist. So the most recent one said, here's how you prescribe stimulants to people who just want to do their job better. And I was like, oh no, you shouldn't do that, So I'm reading the article, and to be fair, this neurologist is talking about how we might prescribe medications, stimulants to patients who want to perform better on the job, but don't have a psychiatric diagnosis. He goes on to say that, there are bad outcomes from using stimulants, including psychosis, paranoid psychosis. And you don't want to do that if, in my opinion, that's an inappropriate use of a stimulant, is to give it to somebody who doesn't have ADHD or some other neurocognitive disorder where they would benefit from the stimulant. Because on my unit, on the professionals program, I get patients who come in there who, as adults, walk in and say, oh, I got ADHD, they get a stimulant, and they get paranoid. And So they come to my unit and they're paranoid, and I go, we need to get you off the stimulant. Oh, no, you're not touching my stimulant, you know. So that's a very difficult situation. And when I hear people who are not psychiatrists talk about trying to get patients in to see a psychiatrist, it's very difficult, and you've got a psychotic patient. And so I think that that's an inappropriate use of a stimulant. Now, there is such a thing as adult ADD. But if it's adult ADD and they didn't have it as a kid, it's probably not ADD. So in DSM-4, to have ADD, you had to be diagnosable by age 7. In DSM-5, they raised it to age 12. This is the way, in my experience, people get diagnosed with ADD in most general medical and, yes, psychiatric clinics. Adult walks in and says, oh, I was diagnosed with ADD last year and they put me on Ritalin and the results were amazing and I could focus. Oh, what dose? Well, you know, I think that's inappropriate. ADD has specific criteria. They have inattentive criteria and they have hyperactive criteria, and you have to have 6 of one or 6 of the other or both. So you can be primarily inattentive type, primarily hyperactive, impulsive type. So they have these are the inattentive criteria and these are the hyperactive criteria. So these are sort of disclaimers that all psychiatric diagnoses have. You know, they have to create symptoms interfere with or reduce the quality of social, academic, or occupational functioning. I wish I had a buck for every time some kid or some adult comes in who made good grades in school thinks they need a stimulant, you know? Well, you know, if they had good grades when they were a kid in school, they probably don't have ADHD. So these are the modifiers: combined presentation, which is the usual type. Then you have predominantly inattentive, which is what adults tend to devolve to when they have residual symptoms, and at least half do. And then there's a predominantly hyperactive type, partial remission, which is probably at least half of adults, and then mild, moderate, or severe. Now, if an adult comes in and says, I got ADHD, but I didn't have it when I was a kid, then the question becomes, what do you have? And you have to seriously consider depression, bipolar disorder. There's a lot of phenomenological overlap between bipolar disorder and ADHD, but also a lot of comorbidity. The comorbidity for ADHD, by the way, is 80% with another psychiatric disorder like depression, substance use disorder. Could be generalized anxiety disorder. Drugs abuse is a big one. Had a lot of patients who come in wanting a stimulant who are on high-dose opioids or who are using cannabis pretty heavily. You need to get them off the cannabis. Then there are medical things like, you know, you don't see a lot of these, but carbon monoxide toxicity, heavy metals, Pick's disease, Huntington, multiple sclerosis. Anybody know what Pfisteria is? Anybody from North Carolina? Yeah, so Pfisteria is a protozoan that lives in the Neuse River, I think. It's in the Neuse River, and fishermen who fish in the Neuse River will get this protozoan that burrows under their skin and elaborates a toxin that gives them neurocognitive symptoms. So these are the kind of things you got to think about. Lyme, you know, when you have somebody who's an adult who did not have ADHD as a kid but believes they have it now. So I have ADHD myself, so this is not my favorite slide. But, you know, this just shows that if you have ADD, you're more likely to get arrested and go to jail. And in fact, you know, I showed yesterday that book by Michael Stone, The Anatomy of Evil, and he says he thinks most serial killers have ADHD, and I'm like, great, you know. But also, I think this one just shows that most people who have ADHD don't get effective treatment. Okay, so ADHD is calibrated to children. None of the number of symptoms and the symptoms themselves, the threshold, have not been statistically validated in adults. According to DSM-4, that phrase is not in DSM-5, but DSM-5 goes on to say that it's got to start in childhood. It begins in childhood. The requirement that several symptoms be present before age 12 conveys the importance of substantial clinical presentation during childhood. Adult recall of symptoms tends to be unreliable, especially if that individual wants a stimulant. Go figure. So there's scales that you can use. I use these scales not to help diagnose ADHD, but to justify using a stimulant. I feel like there needs to be a case made for using a stimulant because the potential morbidity is so high. So it's easy to do false positives, but the Wender-Utah criteria and the ASRS version 1.1, that's the World Health Organization scale. I administer to these to people if I'm thinking about prescribing a stimulant, just to build a case. There are more objective ways that you can diagnose ADHD. There's something called the continuous performance test that psychologists can do. It's hard to fake. Unlike history, unlike the ASRS version 1.1, unlike the Wender-Utah scale, it's difficult to fake. And so this is the closest you can get to relatively easily making an objective diagnosis of ADHD. There's a guy in Montana, a neurologist, who says that if you send him an EEG of your patient, he can diagnose ADD or not and tell you which medicine to use. I'm dubious of that. The SPECT, which shows the dopaminergic activity of basal ganglia, obviously is a good way to diagnose ADHD, but it's get a lot of radiation, and it's thousands of dollars. So none has been shown to be superior to clinical diagnosis. And this is true, but because I'm reluctant to prescribe stimulants to adults, I was ordering the psychological testing when I was at the VA in Bay Pines, Florida, and the service chief got kind of cheesed off at me because it was expensive. So the treatment of ADHD, there are 3 medications that are FDA approved for adults: Concerta, Vyvanse, and Strattera, which is a non-stimulant medication. There are some that are on label for children but off label for adults, like clonidine and guanfacine, and then your methylphenidates. And then off label include Wellbutrin, modafinil tricyclics, and dextromethorphan. Tricyclics were used early on and found to be effective, which to me is counterintuitive because of their antimuscarinic effects. But stimulants are contraindicated with monoamine oxidase inhibitors. Patients can get priapism and sudden cardiac death, and there are even case reports of sudden cardiac death in children who are treated with stimulants. It's admittedly a rare phenomenon, as is the priapism, but psychosis is not rare. And when you've got a psychotic patient, you've got your hands full. So my threshold for prescribing a stimulant to a patient with a substance use disorder is a year of abstinence, and then surveillance urinalyses for substances of abuse. And for patients who are over 40, the blood pressure and heart rate need to be monitored because of the potential for cardiovascular toxicity. So these are the methylphenidates. So the stimulants come in 2 types, the methylphenidates and the amphetamines. The methylphenidates tend to be shorter acting, but there is the Daytrana patch. And then these are the amphetamines. And you can see they're a little bit longer acting in general. Most patients say that no matter how long acting the medication you use, they wear off too soon. So they'll say, it wears off while I'm still at work. Now this is Strattera or atomoxetine. It was originally meant, Eli Lilly was going to use it as an antidepressant. It failed antidepressant trials but did well in ADHD. Unlike stimulants, which you can tell, one of the big benefits of stimulants is that you know within a couple of hours whether it's going to be effective. With atomoxetine, it takes 1 to 4 weeks, and there's significant side effects that make it an unattractive option for older adults. Now, Wellbutrin works pretty well. We avoid it in patients with eating disorders. Note that the jar that I used here, the bottle, has the XL. In my experience, the short-acting works better. It behaves more like a stimulant. If I have a patient who wants to try the long-acting, I make sure they're doing well on the short-acting first, and then I'll try to transition them to the long-acting. No offense. Okay, so clonidine and guanfacine are actually also effective in ADHD. They're as effective as the other non-stimulants and less effective than the stimulants, but still effective. Obviously, long-term use of a substantial dose can lead to rebound hypertension if stopped suddenly, but these are very effective agents as well. So if you're on the fence, you obtain collateral history like from parents, but parents' recall is only slightly better than the patient's recall. School records are the gold standard. You know, does your mom still have your report cards? I have mine, and it's an open and shut case. But I had a patient at Bay Pines, and I asked her, you know, she was an adult wanting a stimulant for ADHD. She brought in her report cards, and it was clear from her report cards that she had ADHD. So then, if I'm on the fence, I also administer the Wender-Utah Criterion ADHD questionnaire just to build a case. So a rational approach is, does the patient meet criteria for ADHD? If they do, then, you know, was there evidence of childhood ADHD? If there is, then treat. If there's not, the question is something else going on? Like one of those general medical conditions, an occult substance use disorder, occult mood disorder. So when do I use a stimulant? If there's a recent history of substance use, I do not. If there isn't, and I'm convinced that this individual had ADHD as a kid, I will sometimes use a stimulant first line. But if not, if there's a recent history of substance abuse, I start with bupropion usually, sometimes atomoxetine. And if that's not effective, I'll add clonidine or guanfacine. And if we move on to a stimulant, at least I've given them a therapeutic trial of something less harmful. So again, I think it's inappropriate to use stimulants if the patient doesn't have a diagnosis that warrants it. One problem I used to get into using stimulants with adults is that the patient would call me or come back and say, you know, that worked really good, but it didn't work enough, so I just doubled the dose. And, you know, so, and I make sure they understand before I prescribe it that they can't do that. They have to call me first. They don't make unilateral changes in dosage. I get surveillance screens for urine screens for drugs of abuse, and I discontinue all benzodiazepines. That's a huge pet peeve of mine, is a patient who's on both a stimulant and a sedative. Now, this was something that was commonly done in psychiatry years ago when we first started using stimulants, because it is true that when patients' levels start to wear off of the stimulant, many do experience some anxiety, and so they were given short-acting benzodiazepines, but in my experience, that's actually a bad idea. So if you're going to prescribe a stimulant, make sure the patient has ADHD, they meet diagnostic criteria. Remember, there are significant downsides to using stimulants, so it would be inappropriate to use them without doing so in a very structured manner. Okay, so now we get into benzos. This is another pet peeve of mine. Benzodiazepines have addiction and abuse potential. They can suppress respiration and cause hypotension, although to a degree less severe than like barbiturates. I don't think they are for chronic use. I think they should be avoided in patients on stimulants. I'm not sure I noticed that said Facebook on it when I used that picture of the pill there. But it's inappropriate to use benzodiazepines in PTSD. Patients with substance use disorders, I think it's inappropriate. Patients with sleep apnea, especially if they're not on CPAP, patients on stimulants, and long-term use, I think, are all inappropriate use of benzos. This is the VA Ptsd Guidelines that were published, the VA DoD Guidelines published in 2013. Notice how it says benzodiazepines harm. It's the only medication where they made that point in these guidelines. They say benzodiazepines are harmful. Anyone here work in VA? Okay, what percent of the patients with PTSD are on benzos? A lot, because we all put them on and all after Vietnam, you know, thinking, I mean, it was classified as an anxiety disorder, you know? So when VA realized, when they got empirical instead of rational, they realized that it was harmful. They published this brochure that they were distributing to veterans saying, your psychiatrist is going to try to get you off of benzodiazepines, and here's why. So, are you guys familiar with the potential increased risk of dementia, or now we call them neurocognitive disorders, in patients on benzodiazepines? A couple of important articles have appeared in the British Medical Journal. The only negative article that I found was done in the United States, and it said, you have an increased risk of Alzheimer's if you're on low-dose benzos, but not on high-dose benzos. I'm like, please, that's meaningless, you know? So this one was a study from France that showed that there was a 50% increase in the risk of neurocognitive disorders in patients who were elderly who took benzodiazepines. And so what people who were in favor of that started saying was, Well, see, what was going on actually is anxiety is a common presenting symptom of neurocognitive disorders, and so what we were treating was a neurocognitive disorder and not anxiety, but that was actually corrected for in a study out of Quebec that showed a pretty similar thing. So we don't know for sure, but it's reasonable to be very concerned about the use of benzodiazepines for their neurocognitive effects. This is an article that was in Psychiatric News, and this guy said that while the percentage of people who become addicted is not known, we know that 1.5 million Americans use benzos for non-medical purposes, I guess partying, you know, every year. They're very useful medications for acute alcohol and sedative hypnotic withdrawal, acute seizures, catatonia. I mean, it's like amazing when you use them in catatonia. Akathisia, you know, in Greek, kathesis means sitting down, and if you put an A in front of something, it's the opposite, like the akathist hymn, you know. And so they work very well for akathisia. In acute psychosis and mania, they're very good in mania, but long-term use for anxiety disorders is just not helpful. People with panic disorder benefit early on when co-administered with an SSRI, or an SNRI, but then has to be discontinued within the first month. And he talks about a lot of providers think, well, I've got my patient on 0.5 of Xanax 3 times a day and it keeps them from drinking. And he reports that that doesn't work. In fact, most of the time you find out that they're surreptitiously drinking as well. So that's not an appropriate use of benzos either. So you get tolerance, you get dose escalation. Anxiety probably worsens over time as the brain tries to accommodate and produce more GABA receptors. Depression is very difficult to treat in my experience in patients on benzos. I have to get them off the benzos, and here's when it's really difficult. Over half of my patients experience their depression as anxiety, and some primarily as anxiety. And to get them off of the benzo is difficult. To get them to trust you enough to get them off the benzo so you can treat their depression is hard to do. And then benzos make psychotherapy more difficult because you're trying to train someone to think differently, to behave differently, to feel differently, to have transformative ways of thinking, and the benzodiazepine is a neurocognitive obstacle to that. That's the maze we have at Menninger there. So I think long-term use of benzodiazepines is an inappropriate use of a psychotropic medication. Talk about insomnia. A lot of different medications we use for insomnia. Antihistamines, antipsychotics, antidepressants. The Academy of Sleep Medicine 2008 had guidelines about which benzodiazepine and benzodiazepine receptor agonist, like Ambien, these are medications that are scheduled by the FDA for having addiction and abuse potential, but aren't technically speaking benzodiazepines. BZRA, and they talk about how here you can use this in this circumstance, this in another circumstance. The evidence for all of their recommendations at that time was weak, though. They recommended against trazodone, tiagabine, diphenhydramine, melatonin, tryptophan, and valerian. I don't ever use valerian or tryptophan. Melatonin I use. Did you guys get this journal? With the annals with the mustache on it? So this one really shocked me because they had a couple of articles in there about the use of cognitive behavioral therapy for insomnia. And actually in this article there was a position paper from the American College of Physicians about CBTI should be the initial treatment and treatment of choice for chronic insomnia. Because this is something I face every day in my job. The patient says, I can't sleep, give me this medicine, give me that medicine. I mean, that's what killed Michael Jackson. He just wanted to be knocked out, and my patients want to be knocked out. What happens is they get themselves in a panic over not being able to sleep. And that's the primary thing that CBTI treats, is this idea that I'm going to die if I don't get enough sleep. So CBTI is what we should be doing for chronic insomnia. And if you don't know anybody who does CBTI, there are several online courses that patients can do. I have a patient right now who's doing the shut-eye, uses a Fitbit, and helps them to, and they can give you a code so you can go in and see how they're doing. You can look at their graphs. It's $180 to do shut-eye. I don't know what this one costs. There are about 4 or 5 of these online CBTI programs, but they're very helpful. They're very effective. Now, there was an article written by this guy, DeSalvo, who said you can't diagnose sleep apnea over the internet. And he had some critiques of these studies that show that the online versions are as effective as the in-person versions. I mean, that's certainly true, but that's what we try to rule out in insomnia anyway. And it's not a bad idea if you can, and the patient flunks CBTI, to get a sleep study and see if something else is going on, like restless leg syndrome or sleep apnea. So treating chronic insomnia with medications when CBTI has not been tried, I think, is an inappropriate use of psychotropic medications. Now, when I treat insomnia short term, I usually start with trazodone. Trazodone has a lot of alpha blockade, so I don't like to use much of it in the elderly. And 250 milligrams is probably the maximum safe outpatient dose. Then I might switch to doxepin, up to 300 milligrams. Again, doxepin is a tricyclic antidepressant, so it can have significant side effects. I may use Remeron, and if that doesn't work, go to quetiapine. If it's chronic, I use CBTI. Melatonin really doesn't help people sleep unless their problem is a circadian rhythm issue. If you use 10 milligrams of, there's a really good article in the literature about blind people and how they have non-24, you see that on television. They were able to set their circadian rhythm by giving them 10 milligrams of melatonin for about 3 months. And that, if they take it at the same time every night, it sets their body clock to go to sleep at a certain time. Okay, well, how'd I do? Not bad. Any questions?
We can throw them, but I don't want to knock anybody's drink over.
It's weird holding that box, isn't it?
Yeah, isn't it?
It's meant to be thrown, but our laptop is around, so.
So my question is about when you're about ADD or ADHD. When you're looking back at report cards, are you looking at behavior as well as grades?
Yes,
Comments on behavior, because some children, I believe, can get good grades, but have the inability to sit in the classroom.
Well, so the way I look at that is, if they look restless and they have trouble sitting still, but their grades are good, I don't want to expose them to a stimulant. Because, it's not...
I only treat adults, so I'm talking about if I have back.
Excuse me?
I said, I only treat adults, so I'm talking about looking back.
Right. But if you're looking back and their grades were good, that's an argument against ADD. Even if the behavior is bad, yes. Now, I don't believe in making any solid rules like that, so, under the circumstances, I may consider, like, say, starting with a non-stimulant. But, the point of, with all of the psychiatric disorders we talk about, they have to impair. If they don't impair socially or occupationally, then you have, try not to expose them to medications. And that person would not have been impaired, And it's very unusual to have mild ADD as a kid and severe as an adult. The opposite is the normal way, severe as a child and mild as an adult.
Any other questions?
I've never had any luck with Statera. I mean, what percent respond to Statera?
Well, I don't use a lot of it because in adults, particularly male adults, you can run into sexual and urinary symptom side effects like urinary retention. There are case reports of middle-aged men with benign prostatic hypertrophy going to the emergency room with anuria. For younger patients, I think a lot of the treatment failures are because they expect it to work like a stimulant. And if they've ever been on a stimulant, they're going to say it doesn't work. But it takes 1 to 4 weeks to kick in. So I think there's at least a third get a really good response, but if they've ever been on a stimulant, they're classically conditioned that it won't work. So it's probably not worth the effort in somebody who's been on a stimulant already.
He had one, and I'll get right to you.
Doctor, in which cases do you use T3, triiodothyronine?
T3 for...
T3 for, as an stimulant, when?
I don't use T3. And I tell you the main reason I don't use T3. It makes your thyroid studies look ridiculous. You can't interpret them. You know, the TSH is high, but they're not clinically hypothyroid, so I avoid it. I have used it in depression a few times, but nowadays, if I'm going to use thyroid augmentation in depression, I just use Synthroid because I can interpret the TSH. I can't with T3. So I don't use it in ADHD.
Thank you.
Can you just, what is the actual incidence of ADHD in the population? What's the estimate of the incidence?
So this was looked at in the, well, in DSM-5 it says it's 5% in children and 2.5% in adults. So that's probably the best answer. Now, you get the impression when you get exposed to school kids and neighbors and stuff that it's a lot higher than 5%. And I think it is a legitimate criticism of psychiatry that we prescribe too much and we pathologize ADHD to a degree that probably gets the risk-benefit ratio a little bit upside down. In France, they don't use stimulants for ADHD, but they do diagnose it. They use behavioral techniques. So I think it's probably 5% in children, but I think it's probably overdiagnosed. You know, in the past few years, you know, we used to have recess and gym and stuff like that, but with the No Child Left Behind and this kind of training students to take tests, I think we're seeing a lot more behavioral problems in kids and intolerance of exuberant behavior on the part of the schools.
Did you have a question?
If you use levothyroxine as a augmentation for depression, what lab values are you looking for?
Well, what I try to do is get what looks like really mild suppression of the TSH. I don't want to go too far because I don't want to cause them to get osteoporosis or atrial fibrillation. So, so I may use it and just have a normal TSH, or I may try to suppress the pituitary slightly. But normal to slightly suppressed is what I aim for.
Oh, I threw it. I don't want to knock the drink.
It's not a medicine that I use very often, or try not to use, but what's the role for zolpidem for chronic insomnia? I've got women that have come to me and said they've been on it for 8 years, 10 years, and it's a real problem.
Yeah, I have that same problem. And so I think what happens is it becomes a problem that feeds upon itself. You know, the people who make it say, oh yeah, you can use this for years and never have any problems. I think what winds up happening is that the individual has a non-physiologic sleep. They have an abnormal electroencephalogram or polysomnogram, and so they become sleep deprived over time, and the need for it perpetuates itself. So I try to get them off of it, but sometimes, you know, you have to pick your battles. And I think definitely when they get to be elderly, it gets to be a problem because we can assume that the risk of neurocognitive disorder is there. We can assume that risk of falls is there. You know, I didn't even mention falls when I was talking about benzodiazepines in the elderly, but that's huge. We know that that's a risk. So I think we got to try to get them off, you know, if we can. Okay. One more?
Oh, she has a question.
Okay.
Have you ever used modafinil for ADD?
I have. I don't feel good about it. I mean, it's a stimulant. You know, it's not, you know, the amphetamines and the Ritalins are, I think, FDA Schedule II, so they're just below marijuana and ecstasy, you know. I think modafinil is 3 or 4, maybe 5, so it's reckoned to have less addiction and abuse potential. I do use it sometimes, but again, I prefer to use non-stimulant medications first.